Very good. And that's Miss Yvonne Boos, I'm sorry. And next to her is Representative Spencer Fry. And Mr. Fry is from the red and black area of the state, Athens. And he has a little ball game coming up this Saturday, I understand, sir?
We do. If I seem a little distracted, it's because one of our star players got in some trouble last night.
Oh.
2 nights ago for the first time this year, though. But I'm happy to be here. I appreciate all of y'all being here, too.
Thank you, Representative Fry. And on the end, we have our chairman of my committee, and that is Mr. Tommy Benton. And Mr. Benton, if you could just say a few words about yourself.
Represent House District 31, which is most of Jackson County, and look forward to hearing all the testimony today. This is a subject that needs to be addressed, or it needs to be addressed better than what is being addressed right now.
And to my left, I'm happy to introduce Mr. Matt Wasatomsky, who works with the House. Mr. Wasatomsky?
Yes. I actually am a policy analyst. I normally work with judiciary, non-civil, juvenile justice, and also regulated industries.
And on seat number 1, who gets the prize, Mr. Julius Tolbert from our legislative branch over here, our attorney. And Mr. Tolbert, if you could just say a few words about yourself.
Sure. I work in the Office of Leg Counsel. Coming up, it will be my 4th session, so I am enjoying it thus far and happy to be staffing this committee as counsel.
Well, Mr. Tolbert, we're very happy to work with you, too. And I'm Valerie Clark, and I represent Lawrenceville and Suwanee, and this is a passion of mine, so I am delighted to be here today. And our first guest is Dr. Jay Bulott, and Dr. Bulott is with the Department of Human Services, Director of Aging Services, and he's accompanied by Miss Ashley Fielding. And Miss Fielding, I wonder if you could just stand for a moment and be recognized also. She stepped out. Okay, I'm sorry. Well, Ms. Fielding is Director of Legislative and Governmental Affairs for the Department of Human Services. Dr. Jay Bulott.
Thank you. Thank you for having me. I'm here to talk about the Community Care Services Program and how Adult Day Health fits into that particular program. And we have a very slow computer, I believe. You all have some slides, so I'm going to wait for that to progress as I go through. So CCSP and the Department of Human Services Division of Aging Services help support the mission of the department by providing resources and services to older and disabled adults to allow them to remain in their homes and in communities for as long as possible. We also don't look just at the individual, but also at their family and try to address their needs as well. We're 15-second delay. So the Community Care Services Program is a Medicaid waiver program. We administer on behalf of Department of Community Health, it's 1915C, and is targeting older adults and adults who are disabled. And we work with those individuals and their caregivers to try to identify the resources and services they need in order to remain at home and in the community for as long as possible. We try to emphasize in all of our planning with the individuals their health, independence, and safety. CCSP is more than Adult Day Health. We are able to provide a variety of services, both in-home and in the community. Adult Day Health is one of the services that's available through the Community Care Services Program, as are alternative living services. Some people know those as assisted livings. We do family and group. Emergency response services, that's that electronic monitoring that might be available for older adults who may be at risk for falls or other safety concerns. We do home-delivered services, so that might be skilled nursing. It might be healthcare that goes into the home to help an individual with their healthcare needs. We also provide home-delivered meals for individuals to help sustain them, to provide proper nutrition. We do personal support services, and that's where a caregiver, a paid caregiver, goes into the home and they help the individual with activities of daily living. And that might be bathing, it might be getting in and out of bed, getting dressed. Those activities that all of us need, that we do ourselves to remain in the home. And then we also, for family caregivers, provide out-of-home respite where families who are providing the bulk of the care to an older disabled adult can bring their loved one to a location to provide overnight care, so they have a little bit of respite if they have to go out of town or they have an emergency that comes up in the middle of the night. And this is, okay, it's easier to see on there than it is here. So what I thought would be useful to frame adult day health in the context of the community care services program is look at the number of clients that we serve. We currently have about 9,000 clients enrolled in CCSP. About 1,000 clients avail themselves of the adult day health services across the state. 700 of them live in alternative living services family model. Another 1,600 or so live in a group model home, and then 408 consumers utilize a consumer-directed option, and that's where they identify their caregiver who comes into the home, and that caregiver is paid. It's a non-family paid caregiver. So these are our most popular services outside of personal support services. Personal support services, as I mentioned, are those services that go into a person's home and they provide that hands-on intensive care to an older or disabled adult. You can see we have 9,000 individuals take advantage of that. And you can, if you're enrolled in the community care services program or any waiver service, you have access to the array of services that are available to best meet your needs. So you can see there's some duplication there. We have 9,000 people enrolled in PSS, personal support services, and another 1,000 people in adult day health. There's not 15,000 people currently enrolled, but they receive multiple services. So they may receive home delivered meal and PSS and some level of adult day health as well. So this is our regions. We have 12 regions across the state. The community care services program is, we manage the 12 care coordination agencies in each one of these regions. And we try to focus in on what we call a person-centered care plan, where we work with the older adult and their family or caregivers to build a care plan that best meets their needs with the resources that are available. So for adult day health in particular, this is what our enrollment looks like across the state. Atlanta, the ARC, that's the Atlanta Regional Commission, that's one of our area agencies on aging. The largest demographically dense population center in the state. The majority of individuals on the waiver, the majority of providers of any waiver service are in the Atlanta metro area. You can see we have 477 individuals receiving adult day health in the Atlanta area. It levels off, and we have one region of our state that doesn't have any adult day health providers. Our AAA is able to provide services to 2 individuals, but they use transportation to provide it in a different region. So our approach, as I mentioned, we oversee the care coordination agencies. Care coordination agencies, when somebody is deemed eligible for the waiver, we go out there, we do a face-to-face visit, and we talk to that individual, and we try to understand what their goals are, what their needs are, as we work with them to build a care plan. Now, we approve the care plan, but we're talking to that individual, and we're taking their wishes into consideration. So the care plans that are built will be specific to each individual and their family needs. And that's true across all of our regions, is the approach that we take. So we don't necessarily promote any one service over another. We try to educate consumers on the array of services that are available. And there's always a budget, so individuals have to live within the budget with the services that we have. But we try to target and tailor it to each individual kind of uniquely. And that's the extent of our adult day health and our involvement in it within the community care services program and the extent of use that we see across the state. And I'm available to answer any questions that you might have.
Does our committee have any questions at this time? Mr. Chairman?
Thank you, Dr. Block. What is budgeted?
Budgeted for the community care services program, about $119 million in total funds.
Okay.
For the community care services program, and that's a combination of state and federal funding.
Okay. How much of that is state? Can you tell me?
About 33% is state.
Okay. When was the last time you had an increase in your state budget?
In our agency budget, we received an increase in our non-Medicaid services last year. Roughly, I believe it was $1.5 million in non-Medicaid services.
Okay. Thank you.
Dr. Bulott, has it been a long time since you've received a Medicaid increase?
I think it's been a long time since most agencies received a Medicaid increase with the recession that we've just are leaving right now. But we've been able to manage and hold on to the funding that we had in are able to even to some extent extend services through a variety of ways, maximizing the FMAP that might be available for people who transition out of nursing homes to serve even more people than we would normally be able to.
Very good. Thank you so much. Are there any other questions? Ms. Emmel?
Yes, I know that services are also needed in rural areas. Why do you think those couple of areas have no centers?
I really don't know why they don't have any adult day health centers. I know across the state we look at through our office just the density of services that are available, and we look kind of downstream at the growth of the population, and we have concerns across the board. In the Atlanta area in particular, where we have an overabundance of individuals, we've had several adult day healths go out of business. And that's very concerning just from a service delivery standpoint. We need to have really the entire array of services available, from institutional care to community-based care, and adult day health is part of that continuum. And I think for us to really meet the needs of each individual uniquely, we need to have enough providers of all types to be able to meet those needs for people.
Thank you. Ms. Booth?
Hi. As far as the staffing for the communication with the adult daycare and the case manager, why is there a lack of case managers to a group or area group?
I can't speak to the regulations in adult day health care. If you're talking about the community care services program and the case managers there, or the care coordinators.
Yes, the CCSP case managers.
It's based on a budget, so a part of that $119 million that's available is for direct client benefits, and a portion of it is for the care coordination of those benefits. And we try to identify and push as much services, as much of the funding as possible to the service side.
Gotcha.
So we try to balance based on enrollment, based on wait lists, the number of care, or the amount of funding that goes to the care coordination agencies to meet those needs, while ensuring that the bulk of it goes to the consumers.
Gotcha. But I guess my problem or question with that is what I've saw is, like, in the 3 years, I've had like 10 different case managers, and the rollover, the consistency with the families, I just see that is not good, because if we don't understand the care, then even if we get the care, we need to be able to understand it and kind of work with the
There's
people.
definite value
Yeah.
across the continuum to have continuity of care, and
Right.
From a case manager perspective to the hands-on individual. And turnover in long-term care is an issue across the board. We work with
Gotcha.
long-term care, and it's even higher than what we're seeing here. And then as the economy improves, we're going to experience even more turnover across our healthcare system.
Okay.
So we're doing a little bit in our office just to kind of emphasize the level of training that people have. So when there is a change, there's little learning curve as possible, so care coordinators can step in, hopefully seamlessly. But there's always a little bit of, we got to reconnect and figure out what's going on. So we're able to continue to provide the best services as we can.
Thank you.
Dr. Bulott, to validate what you just said, I know I'm on a committee with Child and Family Services, and they're having the same problem with social workers visiting the home, that there's such great turnover.
As I mentioned, as the economy improves, we're going to see this kind of across the board. In our office, we administer adult protective services, and we've always had a historically very low turnover, especially over the last 7 years. And we are seeing a higher turnover now than we ever have. And it's people leaving for better jobs, better paying jobs. So we're pleased for our employees who are able to do that. But it's challenging for any provider to re-educate somebody. And I know in the work that we've done in long-term care, we've chalked it up to about $1,500 per person for the training that we invest in a person before they can provide proper care. And if you think about high turnover, that adds up.
And it's possibly an entry job because of the salary being lower.
Yeah.
And therefore, they are looking for
Yeah.
a better job being.
Now, for our care coordinators, we do have a minimum bachelor's degree requirement, and most of them have a nursing background. So it's a little bit more skill level that's associated. But when we talk about the ADH staff, we talk about PSS staff, it definitely is entry level a lot of times.
Thank you so much. Are there any further questions from our study committee? Dr. Bulott, you've been so helpful. Thank you very much. It was great information. And I'd like to invite Miss Elaine Wright from the Department of Community Health. And Dr. Wright is the Director of Personal Care Homes Program. And she's going to talk about licensing in adult day centers. And we're lucky to have Miss Lisa Marie Shekel with her. And she's the Director of Communications and Legislative Affairs for DCH. So welcome to both of you.
Thank you. I'm just going to try to get this PowerPoint up, so bear with us on with the computer issue.
I will say I'm not a doctor, but thank you for that.
Did you say the Holiday Inn Express?
I'll just introduce myself while you're doing that. I'll just tell you a little bit about me for a minute. I'm Elaine Wright. I'm the Director of the Personal Care Home Program, which is part of the Department of Community Health, Healthcare Facility Regulation Division. So my program includes personal care homes, assisted living communities, community living arrangements, and now adult day centers. Although the HFR, Healthcare Facility Regulation, regulates all the healthcare facilities in the state, okay? So, but for me, I just have these lucky 5 programs, okay? So, the adult day centers support our mission also of providing access to affordable, quality health care. We will provide access to Georgians through effective planning, purchasing, and oversight, and we're dedicated to a healthy Georgia. Can you hear me good? Okay. All right. So, an adult day center is a facility that serves aging adults, that provides a comprehensive plan of services that meets their needs, which include basic social, rehabilitative, health, and personal care services, which are needed to sustain the essential activities of daily living and to restore or maintain optimal capacity for self-care. Such program of care shall be based on individual plans of care and shall be provided for less than 24 hours per day. So it's not residential. Adult day health services, it's an ongoing program of therapeutic activities. Nursing services and health monitoring are provided. Medication administration can be provided. And physical therapy, occupational therapy, and speech therapy can also be provided. It can be provided or arranged for by the center. The rules and regulations for adult day centers were just effective in January of 2015. And the purpose of those rules were to provide for licensing and inspection of adult day centers, which provide adult day care services and or adult day health services to 3 or more adults. And to establish the minimum standards for the operation of adult day centers and to promote, safeguard, and protect the well-being of adults participating in adult daycare. So that's just our general overview of, I think there was more, there we go. Exemptions. There are facilities that are exempt from our licensure, and we thought it would be important to let you know about that. A center that's not receiving any compensation as a condition of attending the center. Sorry. Yeah. Sorry. Okay. Centers who provide services for compensation to only 1 or 2, because remember we said it had to be 3, and programs who provide day habilitation and treatment services exclusively for the developmentally disabled. So they are exempt. And respite care services programs as defined in the rules and regs. There is an application for license that's required. A separate application and license is required for each adult day center providing services to 3 or more. You may not operate prior to obtaining a permit from the department. And for those centers who were operating prior to January 7th, 2015, when the rules became effective, the license was supposed to be obtained by April 7th of 2015. We're still accepting those applications, however. And the application and rules and regulations are available at dch.georgia.gov under the Healthcare Facility Regulation Division. After you get inspected and after they receive their permit, we will continue to visit the centers, and prior to licensure and periodically thereafter, we conduct complaint investigations. We will investigate every complaint that we get. The application for licensure and issuance of a license constitutes consent by the applicant for the department's representative to enter the premises to determine compliance with these rules. So far we've received 131 applications. We have 77 who are actually have obtained a license out of those 131. 64 are adult day health centers, and 13 are adult day centers. And 7 facilities have already closed. Wow. Now, sometimes they might close for various reasons. They may not have been ready. They may have chosen a building that the fire inspector wouldn't approve. They may just decide they didn't have enough money to do this. So various reasons why they may have closed. That's kind of strange, but so that's where we are. We've had a pretty good success of opening. Most people getting permitted on the first visit. Sometimes follow-up inspections are required. Some of these are pending due to that. Some of these are pending due to maybe the fire inspection requiring some additional work being done or a food permit being obtained. But we've been working with these providers and allowing them to get the information to us without any penalties. Okay.
Thank you so much, Ms. Wright. And do we have any questions from our committee? Chairman Benton.
Thank you. Thank you for the presentation. Of these 77 licensed facilities, can you give me some idea of how large some of these are? You said they just have to be 3 people, but can they be?
The majority of them are much larger than 3 people because the majority of them are adult day health centers. That are reflected in the numbers that Dr. Bulow talked about too, because they're CCSP providers. The private centers are generally smaller, but I would say most of them are 24 and up.
To work in one of these adult day health, is there a job requirement to be able to work in one of those?
Yes, there is.
Right.
There are regulations regarding criminal background checks, training, CPR and first aid, all that kind of anything that's required.
Is there any license that the person has to have in order to, in other words, do they have to have a nursing license, or do they have to have anything like that?
If they're an adult day health center, they will have to employ a licensed RN.
Okay.
If they provide any, of course, therapies that require licensure, people that have licensure, they would have to have those.
All right. Is there a standard cost per
the
person?
I don't have that information. We don't get into the costs.
Okay. Is any of that cost borne by the participants, or is that all? Is this all state funded?
The adult day health centers are generally all funded through the CCSP or SOURCE program. Okay. The private ones that are just adult day centers, they would all be private pay.
Okay. Do you have any idea how much it costs for an individual to be at one of these centers, either health or day?
I don't have that information.
Mr. Chairman?
Does anyone in the audience have
Yes.
that information?
Ms. Madre?
We base our rate of reimbursement based off the CCSP rate of reimbursement. So a level 1, which is a person that doesn't require a lot of medical intervention or oversight, they're $50.45 per day. And a level 2 that needs a little more oversight, and that individual would be a reimbursement rate of $63.07. And that is the rate of reimbursement that we have received since 1998. That has been adult day health's last rate increase. So even though there have been some rate increases in programming. Adult day health has not received one since 1998.
Also, the members may not necessarily attend 5 days a week, because they might attend 1 or 2 days or half days or however it's set up.
So if you own a private adult day center, then it's spotty. It's not. You can't. You can't confirm what your success will be in terms of the number of clients you have, how often they come. It might be just a few times a week. Might be the next week they come every day. Is that correct?
If it's a private, yes, and I see that with all of them actually. That some might attend 3 days, some might attend 5, or 2.
Is reimbursement from Medicare based on the number of days they?
I have to defer.
I will.
Medicaid is the
Medicaid
only,
is what I meant. I'm
reimbursement,
so sorry.
And we bill for the days that they attend.
I see.
So CCSP and the SOURCE program, they will give us the care plan, which was referenced, and it will say they are allowed to attend 3 times a week as a level 1 or level 2. So we can depend on that attendance unless there's an unforeseen hospitalization or whatnot. But the private pay sector, they may say, I'm a husband caring for my wife and I'd like to go play golf today, and then I don't need you for another month. So the private, you really cannot rely on one resource. You have to be diverse to have been able to sustain.
I see. That's very helpful from all of you. Thank you so much.
On your complaint investigations, give me an example of a complaint that would come in and how quickly y'all would go out.
Okay. We haven't had too many complaints, thank
That's
goodness, since January. I got one yesterday, in fact, and this complaint was a family member had brought, I think it was her son, had been attending an adult day, and her complaint was that he was not being changed frequently enough, and that she would pop in and would have to change his diaper, and she was upset about this and actually had removed him from the facility. So we would get out there within 10 days on a complaint like that. Okay. 10, yeah, and generally even before that, but 10 would be our limit.
Okay, thank you.
Mm-hmm.
You would have, I would imagine, and this, do you have a social model and a medical model?
Correct.
Do they mix? Do you have some folks come to your medical model facility that are just there because they need to be supervised for the day?
Yes, the adult day health services provide both, can provide both. The adult day centers that are not health, they are merely a social model. So they would not be able to have anybody that had acute needs, medical needs.
Was there a history of why those folks did not get licensed? Was there some sort of trend as to why they were deficient? You had 70 some odd that got it.
The ones that are pending.
The ones that are pending?
Yes, there is. I would say, a matter of fact, I pulled a top 10 violation list recently. There are things like physicals and TBs. They're mostly things that were not required by the community service program. So they operated for years and years and years without these things. So some of the training, we require a few additional training requirements. We require the staff to have a physical and a TB. Those seem to be the 2 top things that have been cited. And then there have been physical plant issues, maybe not having enough toilets or not having, like I said before, the food permit or the fire inspection.
Very good.
But most of these that are pending are incomplete applications, not that we went out there and they didn't get their permit.
I see.
Mm-hmm. There's only probably a few like that where we're just waiting to do a follow-up inspection.
Very good. I see. Are there any other questions from our committee?
I have one.
Ms. Immel?
And I just want to say you were very helpful in answering our questions during the licensure.
Good.
So that was good. This actually is a question and a comment that comes from our nurse at Georgia Infirmary. And of course, we're moving more toward the person-centered planning that's coming down the pike. And she had a question regarding the care plans and the format that we use. And there's not a real good way to include all the things that you want on that care plan, like the transportation, socialization. And we would just maybe like to look at those forms and see if we can maybe have a forms repository, or just so we have unduplicated forms. But I'm sure if you ever decide to do that, she would jump on the
Okay, so
bandwagon.
you're requesting that we provide forms for you samples of forms to use?
I think there's just some things that, that we could make where it would be more, where centers would be a little more
Uniform?
uniform. That's the word.
Okay. Well, that's not something that we have provided much in the past, or forms, but it's certainly something that we could talk about, and going forward, we might be able to come up with some standard samples, like we have with proxy caregiver forms.
Yeah, so that's just something she asked me to bring up.
Sure.
And you have a ready-made volunteer with her.
I hear. Great. Head of the work group. Exactly.
I have one question. How often do you guys go out to revisit the centers, like if there was not a complaint?
We would go out. Our rules and regs say periodically. We translate that to mean annually.
Okay.
So approximately annually, we will visit the facility. Even if we had been out there on a complaint or a follow-up, we would still come out and do an annual overall inspection.
Okay. Thank you.
Mm-hmm.
Is that an inspection announced or is it unannounced?
All of our inspections are unannounced except for the initial inspection, where we want to have someone there who knows what's going on.
Well, Ms. Wright, as with Dr. Bulot, you have been so helpful. Thank you very much for your presentation
thank you,
today.
and
We
thanks
all learned.
thanks for having me.
Thank you.
And thanks for your interest in this important work we do.
Thank you, and
Appreciate
we
it.
are. Thank you so much. And our wonderful, and Ms. Shekel, thank you also, and really appreciate your all being here today. Our outstanding audience has continued to become outstanding. We have someone who's been so helpful to me, who's just arrived, Mr. Stewart Wilkinson, and we're just glad to have you here. Thank you so much for being here. Thank you, Stewart. And Stewart worked with us in the House, worked for the Speaker, and now he is working still for the state. And Miss Eve Anthony, Director of the Community Council on Aging, if Miss Anthony would join us?
She couldn't make it.
She could not make it, okay.
She would like to maybe get on another agenda.
All right, that would be lovely. Thank you. Mr. Ned Morgans, and Mr. Morgans is the president of the Georgia Adult Day Services Association, and Mr. Morgans has an array of things that he'd like to speak on today. Thank you, Mr. Morgans, for being here.
Thank you much. I wonder if I could
Thank you, ma'am.
these to look at. Hi, my name is Ned Morgans. I'm with serving as the president of the Georgia Adult Day Services Association this year. I've also been the chairman of the board for the National Adult Day Services Association. And so hopefully I can talk a little bit about things that I'm seeing on a state level as well as on a national level. In Georgia, kind of my day job, I am with a franchisee with Sarah Care Adult Daycare Centers. We have centers in Johns Creek, Georgia, as well as in Cobb County. And we are serving anywhere between, at each of the centers, about 40 people every day between those two centers. I'm going to refer to the handout in just a second. As I'm looking out at the Adult Day in Georgia, it's an interesting mix of what I'm seeing and hearing from different providers along the way. On the positive level, we continue to have one or two new centers open every year. On a negative side, the National Adult Day Services Association maintains a very strong database nationally, and so we pulled up some just trying to figure out how many centers had closed recently, and according to their database, they have records of 12 centers closing since 2012, and that would be both kind of a social model as well as a kind of medical model, which really is is always going to be a combination of a social medical model, because you can't bring 40 people into one spot without them actually having conversations and being very, very social. As well as you got to do a lot of things to keep them there. That number would include a few of the folks that have closed since licensure started, but probably does not include the overall number. So it's probably, with the 7 that Ms. Wright referred to, the actual number is probably a bit over 12 since 2012 that have closed. Had some thoughts that were coming through, and really concerns that the Georgia Adult Day Services Association has. I'm also very active in the Georgia Association for Community Care Providers, and I would say a lot of these things would be things that I hear from their members and that we all have. One of the top issues that we're concerned about really is that reimbursement rate for Medicaid. It really has not, it has not changed since 1998. We're the only service in the SOURCE and CCSP programs who have not received a reimbursement increase. And it's kind of probably, I think 2 years ago, all the other services received a 5% increase across the board, and we were lucky enough to be excluded from that list, so to speak. In terms of, and obviously that has a huge impact on business decision making, and so I think one of the most prominent closures that happened in the Atlanta area is when the Weinstein Center at the Atlanta Jewish Community Center closed. They were one of the first adult day centers in the state of Georgia to open. Had been open since 1980, and they closed for a variety of reasons, some missional, some other things. But I think it's almost impossible to have a conversation with the folks there and not realize that they're feeling the pressure of reimbursement rates not increasing, the increased regulations, regulatory requirements, the different things that are happening with the Medicaid funding, because for the vast majority of our centers, if not, when I say vast majority, I'm talking 95, 99%, are really going to be dependent. If they're the adult day health model, they're going to be dependent on a sizable portion of Medicaid funding. We're also seeing some other centers leaving Medicaid. So the Guest House is a prominent example of that in Gainesville, which is one of the few centers in the Legacy Link AAA service area. And so they no longer have, that's opened up a huge gap of service providers. They're non-profit, so that they've made a commitment to serve the financially needy, but they're clearly not going to do that through they're no longer doing that through the Medicaid programs. Wanted to talk a little bit about other forms of revenue mix. So we were talking a little bit earlier. There are probably 4 sources of revenue that adult day centers would have, or possible revenue sources. One is certainly adult day health, not so much the social models, or not at all the social models, but for adult day health. Medicaid's going to be probably one of the top sources of revenue. Then private pay, and I think that depending on where the centers are are located. I think we've got one center that I've heard of that's 100% private pay, that's mostly following an adult day health, but is technically still a social model. Some at the high end, maybe 30 to 50%, they're doing really well. However, the vast majority of adult day centers are located in lower income areas, and so the private pay for many of our centers, the private pay market is really not much of an option. There are some centers that are able to contract with the VA, the Veterans Administration, through a direct relationship with the VA. Depending on which VA medical center that you're associated with, the contract amounts might be great, but you may only get one or two. You're lucky to get one or two people out of that. So it's a weird funding source. And then every once in a while, we will get a long-term care insurance, a family with long-term care insurance that would pay basically a private pay rate, but they do have the long-term care insurance coverage. But that's really a very tiny portion of that population. One of the things, so the next thing I wanted to talk a little bit about was utilization of adult day health, and what I this little handout that I had here. Early in 2014, I was just kind of curious about how CCSP and Source were using adult day health, and I talked to Janet Rohrbach, and this is the data that she sent to me, and I think the big takeaway is kind of looking at that year, the time period between 2009 and 2013, is that there's really been overall a fairly significant decrease in CCSP using adult day health as a provider source. In Atlanta, in the ARC would be the Atlanta region. It's down 20% overall. If you add all these up together, it's about a 10% decline across the state. One of the things that's particularly galling for me as an adult day provider is we really think and believe strongly that we're probably the most cost-effective service that is available to the Medicaid program in this long-term care mix. And so we're not really sure where everybody else is going. But for instance, if you were to look at one of the other home and community-based services available is called PS, Personal Support Services, which is a home care service. For about 2 hours, which would be a standard service at $18 an hour, that becomes that's $36 for that visit. For $36, you can pay for a half day of adult day health, and bring them into the center for the exact same amount, but you're getting at least 3 to 5 hours of coverage at that point. Most of the time, the half day is not utilized, except if centers will, if the service coverage isn't there, the center will charge the state for a half day as opposed to a full day. But generally, what you're going to get in that service for that service time is you're going to get nursing care, watchful oversight at the very least, even if they're not getting a whole lot or need a whole lot. They're checking, nurses checking in with them once, twice, or more times a week. You're generally getting meals. They're being served appropriately. If they, so that the needs for the home delivered meals are not there. There are a lot of unofficial case management duties that all of these centers are providing, and so families have issues. Oftentimes, our nurses are the first ones to get a call. Is this something that can wait till the doctor's appointment next day, or do we need to go to the emergency room? And usually, I would say the experience for most of our centers is we can, those phone calls get people to the doctors, get them to the right service location, and avoids a lot of the emergency rooms. visits, or if there's an emergency room visit, it's really a necessary visit. Somebody is just starting to have a stroke. Somebody's just starting to have the heart attack, so things are being caught relatively early. But I think that this utilization is a big issue for us, and it's just, we're all noticing this big decrease in referrals from probably both Source and CCSP, and we're not really sure why that is. And probably a point of follow-up for the committee, if it's possible, is to really look at the numbers over a 5 to 10 year period of time, understand what, probably looking at percentages to understand how is adult day health being utilized. I know that a couple years ago, the Departments of Community Health and Division of Aging Services and the Medicaid manual allowed for folks that are in personal care homes through the CCSP source benefit to also receive 2 days of adult day health. We took an informal survey at our last meeting, and really it's a tiny fraction of the folks that are in these personal care homes are actually being referred to adult day health and taking advantage of these additional services that are in the milieu of what they should be offered on a given day. Another concern that we have is with the transportation, the non-emergency transportation program, and the way that transportation works really for Medicaid, and it's an issue for private pay folks as well, but in Medicaid, it's really been an issue, especially since 2012, when the transportation contract was changed, and they instituted service limits. And so, for the vast majority of healthcare services, if somebody needs non-emergency transportation to the doctor, to the hospital, Medicaid will pay for that, and it'll be up to a 30-mile distance from the person's home to that service. The contract for adult day health is 15 miles, and it's a very strict 15 miles. If it's 15.1, it won't, the program won't pay for that service. There are that one change in the contract probably scared off a lot of case managers from referring. A lot of families got very frustrated that they were at 15.5 miles. There was another center that's 14.5 miles away. They have a choice. They only would end up having a choice of one center, and they're not really comfortable with that program, and they want to go to this other program, and so it really put a damper on, had a very negative effect on centers in terms of being able to interact with case managers and to be able to handle case managers, the whole process of referrals and intake process. I would also say with that, there are a lot of service issues. Some transportation is broken down into different regions of the state. Some of the brokers that are involved have kind of improved their services over the years. And then there's certainly some other brokers who are haven't quite figured out how to serve adult day health providers. So it's not uncommon for somebody to be picked up 3-4 hours late, stay on a bus for 2, 3, 4 hours to get them home. Just a lot of questionable service issues for these centers.
Mr. Morgans, may we ask you questions in between?
Absolutely.
Study committee, are there questions at this time? I have Mr. Chairman Benton.
On your closings, what would you say is the number one reason that the centers have closed?
You know, I think that it's hard to say. It's hard to say for certain. To some extent, what you hear from the center, oftentimes really what happens is the center closes and you don't really hear about what's going on and why that's happened. I know in one case, the center just wasn't able to get the referrals and wasn't able to pull in the clientele that they were needed to be able to do, and they were located in an area where a private pay marketplace really wasn't that option, and so just people weren't being referred into that program at a high enough level. I think when you start looking at a decrease in the referral stream, you start looking at really some significant regulatory requirements that face all of our home community-based service providers, but the adult day health programs are really feeling a lot of those pressures. It becomes very difficult to run a program and keep it large enough so you can experience some economies of scales in order to stay open or to keep it and make it worthwhile to stay open.
Okay.
And I think we're at that point where I'm not sure that providers are really seeing that it's worthwhile to stay open.
In other words, they're in it to make money, and the reimbursement rate, along with other things, the cost of help, and all that is becoming prohibitive. Would you say that's?
I think that's kind of where we're heading towards.
Mm-hmm.
I would be. Obviously, providers need to be able to make money. They need to be profitable. I don't know that any of the providers are just
rolling in the dough.
Rolling in the kind of rolling in it. But if you're consistently in the red every year, there's only so far you can go. If you're only making, if your profit margin's like 1 or 3%, it's difficult to actually be able to run the program on a continuing basis and provide for your staff and your families and all those things that need to happen.
On the reimbursement rate, I'm new to a lot of this stuff and a lot of the terminology, but is this one of those things where the more the state spends on the more is pulled down from the federal government?
So I would think that it would be part of that, the FMAP.
Okay.
map.
Well then, can I look past you to Dr. Ballot?
He would be the expert.
He would be the expert. That's right. Doc, do you have any idea why this reimbursement rate has not been raised in 17 years?
I suspect that it has to do with the state budgets that we have.
Well, I can understand the last 7 years, but before that, go ahead.
I couldn't speak for what was going on way back then.
I understand.
But I know currently, in order to draw down additional federal funds, you need to have the additional state dollars available in the program itself. So until there's an increase in the available state dollars, you can't draw down the federal dollars to match it.
Do you know whether or not there has been a request? I know that all the agencies are turning in their budget or have turned in a budget for year 17. Can you tell me whether or not there has been a request for a rate increase for this?
That would be in the DCH budget. I wouldn't know.
You wouldn't know that. Yes, ma'am.
That was not in our recent request. We have presented our budget to the board in August, and a rate increase for this particular provider was not in that request.
Okay. Was there a request from the providers, was there anybody out there speaking for these people that came in and said, we need a rate increase?
I'm not aware of any of those conversations. I haven't been reading the notes.
Okay.
Whether or not they have approached the Medicaid program and spoken with our policy folks. And I don't
So if,
certainly if there's additional information that y'all need at our next committee hearing, I'm happy to bring somebody that's more appropriate to speak to some of those budget questions you have.
so in the governor's, apparently in the governor's budget request for the year 17, there will not be a request for any increase for the reimbursement. Would that be a logical, and I hate to assume anything.
No, I think what I can say today is that it was not in our departmental request.
Okay, so we don't know what the governor might come in and say as far as the departmental request. We think you ought to, we see some additional money in some places that we wouldn't have that information. So basically if we're going to increase this reimbursement, it's going to be up to the legislature and the governor to come together and say we need to increase. I'm study committee bound right now. I was in one yesterday in Dalton, and it's the same story everywhere. That for some reason we haven't gone up when we could have, which was maybe with the recession when it came along was probably a good thing. But I'm concerned that we're losing out, and I'm just speaking for myself on that. Thank you.
Representative Fry.
What do you know that ratio of state to federal dollars? Does anybody know that?
Yeah.
What we're looking
right
at?
now it's roughly about 33.6% state, and then the remainder are federal dollars.
I mean, as far as, so that's our spending ratio as well. So we get that 67% for every 33% we spend. Thank you.
Thank you, Representative Fry. And Ms. Madre, I see that there have been requests. Did you, sir, could you speak to that? Yes, sir, Mr.
Commissioner, he's very gracious. Of course, in fact, I spoke with him yesterday about this department with Cloud Reach Department of Community Health. They're under, in their defense, they're under the direction of the governor to have a flat budget besides the Medicaid overall growth that they were allowed to ask. You know, he was very gracious, but certainly it would be up to the governor's office or the legislature to have any additional. And as a matter of fact, we did actually receive a rate increase across the board for all home community-based services in 2008, 10 or so, right when the recession started, and it was rescinded. Governor signed it and everything, and then it was rescinded back, unfortunately. So, yes, ma'am.
Dr. Bullock, could you possibly speak to why Medicaid gave an across-the-board 5%? This may be out of your purview, but to other agencies and then omitted it to this one group?
I can tell you the agencies that received it, or the services that received the funding increase. There was a funding increase last year for assisted living, alternative living services, group and family, and PSS services. They received a 5% rate increase. And I imagine it's probably for a lot of the same reasons that we're hearing about today. It was being able to be competitive, being able to provide quality services, being able to allow businesses to remain in business to meet the needs that we have.
Thank you so much. Representative Fry?
Is there a specific number that would help change the world on this that we need to shoot for? So we have anybody have a hard target? You want to tell me in private later? Whatever you want to do. I just want to, I mean, you know, is it like 5% or just?
Well, if we could put a number together and kind of a recommendation together, but certainly the 5% was what the other services received. If we could, I think a 10% would be a.
Would be make up for lost time. 10% would be
Well, I mean,
great.
Yeah, it just gives you something to shoot for. I mean, we've got
right. Yeah, and you know, I think one of these things is like this is a balancing act of if the services are being utilized, you can realize some economies of scale, and so it's easier to make ends meet on lower reimbursements. But if the services aren't being utilized as much as they might be able to be utilized, then you obviously have to have a higher service, or higher reimbursement rate for providers. I think the last thing I would just want to highlight for the committee to be aware of is at the federal level, there is a new home and community-based services rule that really is going to impact the adult day health community here in Georgia, and really across the country. Yes, ma'am.
Mr. Morgans, we have one more question on
Okay.
your previous
Yes.
presentation. If we could ask Ms. Booth. Thank you so much.
I had a question about the referrals. How do the daycare or day center, how do they work with the CCSP program with getting the referrals? Like, do y'all let them know you have a vacancy, or how does that work?
Well, I know in the case of with Sarah Care,
Yeah.
our nurses, every time we're talking to the case managers, we're asking if they have any referrals, any kind of conversations. The referral process in Medicaid for CCSP, and really it works almost identically in the source program, is an individual family is going to either contact the provider, or they'll contact the AAA, the Area Agency on Aging. And if they contact us first, we will make a referral to the Area Agency on Aging in terms of where they live. At that point, the Area Agency on Aging does an assessment, verifies that they qualify both financially as well as for medical reasons. And so somebody, you have to meet an intermediate level of care for a nursing home placement to be in an adult day health program. So it's not just enough to be, I'm 90, I'd love to see more people, and I've got tons of money. I have no money. I have a physical need, and we need services in order to stay in the community and stay out of a more institutional type of environment. Once everything's approved at that point, the individual is going to be assigned a case manager who is supposed to go and meet with the families, help them understand what services are available to them, and then refer them out to various service providers. And it's supposed to be done mostly on a rotational basis, so the providers are not supposed to necessarily say you should go to this place or this place. It's supposed to be it's supposed to work fairly independently of that kind of influence. I'm not sure that their case managers, they're not necessarily selling the services of saying, hey, you really should be trying out adult day, or have you thought about, you'd love to have somebody come in for come into your home to help do house cleaning, but that's not really these aren't really the services that need to happen. They are overworked. They have a lot of requirements. So one example is they used to have to meet with families, an individual 3 times a year to do a new care plan. It's now recently it was increased to 4 times a year. And so they're not increasing staff, they're just increasing responsibilities for that.
Thank you.
Thank you, Ms. Booth. And Representative Fry.
Thank you. I, like Chairman Benton, I'm trying to get my head around all this, so I'm going to ask you a couple more things. But the biggest one I've got is does this industry fall under the purveyance of the certificate of need?
It does not.
Okay.
Yeah.
It has nothing to do with it.
No, there's no certificate of need. The requirements of, from a facility standpoint, you need it's like our centers are located in a regular office space. It's built out for specific needs, but it's not, we're not putting in a $5 million imaging machine.
Thank you.
Thank you, Representative. And we're sorry that we interrupted you, but this
Oh,
is
no,
very
more the
important.
merrier, yes.
What you're saying is so important to us, and thank you, Mr. Morgans.
Yeah. I think I'll highlight one other things. Obviously the CCSP, there's been a freeze on services, so I don't know if Dr. Bulot referred to that or not in his presentation, but I think that's had a very negative impact on services. So since January of last year, in each of the 12 AAAs, one person has been admitted to CCSP for that time, and so the overall program for CCSP has shrunk fairly dramatically during that over the course of the last year. And of course, anytime there's a freeze of services, that impacts the provider community as well as the individuals who are in need of services. I think the last thing I would talk about would be this: the Centers for Medicare and Medicaid Services issued a new home and community-based services definition, which has radically changed the definition of these services and what kind of settings these services, adult day services, are going to need to, what do they need to look like? And this is a fairly dramatic change for the adult day community. Brian Dowd spoke to who runs the Medicaid waiver services for DCH, spoke to GADSA recently, and his feeling is that this rule will affect the alternative living services community as well as the adult day fairly dramatically. And so what this rule really is saying is that they're trying to get to a point where if you're going to provide services, Medicaid services in these settings, adult day or alternative living services, they need to be integrated into the community, which sounds like a really nice idea. The trick is like if you've got somebody who is in our centers, we have a lot of folks with Alzheimer's and other forms of dementia, many of whom are wanderers. It's not like we can really integrate these individuals directly into the community at all times, and whenever they want. A lot of what we have to do is be able to control their access to doors, make sure they don't wind up on I-75, and you don't want to necessarily want to go to the mall. And so there is this conundrum of what's being required by the feds in terms of these services, and then what's happening here on the ground for adult day services, as well as a whole host of a lot of these other Medicaid services that are trying to help deinstitutionalize individuals, keep them in their home and community for as long, as best as they can. It's going to cause. It's really going to be a challenge from a regulatory standpoint. The community is. I would say we're having a hard time getting the guidance that we're going to need to really be able to figure out how do we respond to this. And I think the main reason why we're having a hard time getting that guidance is because the folks at the Department of Community Health are really having a hard time getting that guidance out of CMS. But it's causing a big issue. And my guess is you're going to see some centers that aren't really willing to, are going to have a hard time wanting to wrestle with this level of regulatory uncertainty.
If I may ask a question,
Yes.
Mr. Morgans, I was blessed with being able to attend your meeting the other day to prepare for this meeting and learn some things before this happened. And one of the things I heard that there might be a dispensation for your group of services because they are so different in what you provide. And I think DCH is possibly working toward helping that happen. I know that's a federal decision, but is that true? Is that what's happening? Hopefully.
I think that's, I think from what Brian Dowd communicated to us is they're basically going to ask for heightened scrutiny for all adult day health programs that will allow them to continue to operate. Whether or not CMS is going to allow for that, and I think they're also going to do that for all the alternative living situation providers as well. What that really ends up meaning, and even so, there are likely some significant changes programmatically and perhaps also from a facility standpoint that providers are likely to have to engage in order to meet that higher level of regulatory scrutiny.
I think you've made it very clear that the adult day services just do not fit into that category of having to be community-based in many ways.
Yeah, well, in some ways, we are probably as community-based as anybody, because what we're doing is we've got people coming from their homes. I've got folks, to our centers, in some cases, 30 plus miles. They're coming from, I don't know if you want to call Dawson County rural anymore, but, certainly the exurban Atlanta areas as well as more urban areas, they're all coming to the center. They have a wide range of diagnoses and disabilities that are taking place. We have, I think in Forsyth County, my guess is we are the most diverse plot of land between 9 and 5 every single day. We've got participants and staff of every single nationality, every single color, all around there. And so it's hard for me to say, we're not part of this community. Now, there's some biases that we've been told that it's more about disabilities communities as opposed to the aging community is kind of pushing some of this stuff. But it's hard for me to say, we are as community-based as you get. In some cases, if you look at take personal support services, if I'm sending somebody into an apartment that's maybe a studio apartment, they got their 4 walls. They get their aid a couple hours a day, a few times a week. They might as well they could be in a lot of different environments, but it's hard to say they're integrated into that community without getting out and being involved in different
So it's
services.
very community-based. It just does not fit that narrow definition.
It doesn't fit the definition the feds are coming in.
Understand.
My guess is something's going to happen because I don't think the feds are going to, obviously people change and move their jobs, but I can't imagine that they're going to want to shut down 6,000 centers across the country and all those employees and all those families that want to take place. But it is an issue that Georgia adult day centers are going to have to grapple with and understand and wrestle with.
Mr. Morgans, thank you. Again, thank you so much for your contribution today. It was very helpful to us.
Thank you very much.
Thank you so much. And Ms. Pat Madre, if you could join us at this time. And luckily, Ms. Madre is a provider at one point from a rural center, so she can come from that perspective, and because she has been both rural and urban. So thank you so much for joining us today.
Thank you, Madam Chairman. I appreciate the opportunity to be before you, and I love following everyone. That I just want to say yes. And I told Steve, I said, I'm about to bust. I cannot wait to get up there and just speak to this because adult daycare is my passion as well. I was a physical therapist assistant. I worked in the nursing home setting for 6 years and a private practice for multiple years. But my husband had an entrepreneur streak, and I said, if you want me to do a business, this is what I can do well. And I think adult daycare, it is the most it is community based. We are a community. We serve people in community. We are the most comprehensive program. When you talk about community-based programs under the CCSP umbrella, you're looking at home-delivered meals. We provide a meal. You're looking at the PSS, the support aid that comes into the home. We not only provide those services of ADL support, we are that community. Isolation is so depressive. Anyone that has to stay in their home, if their family's not there, it's not something that we do as far as we are there for the caregiver. That is one thing I did not realize as much until I started providing the service. We support these families. We are peace of mind to know that while they are working, their loved one is in a safe, secure environment where their medical needs are being met, their nutrition is being met, their social needs are being met. It is so very comprehensive. Years ago, I had a case manager say, I want to use adult daycare because I like to get big bang for the buck. And it is that. We do have individuals, I speak to myself, I'm sure Ned and other programs do. We have community groups come in. We have church groups come in. We have youth groups that want to serve during the summer. We have bands and yodelers and whatever. They come into our center to be part of that community for our individuals. So the push for us to go further into the community, most of us do not own transportation vans. We are still functioning under that 1998 rate. To provide transportation ourselves, we would have to become a non-emergency transportation provider. That is another level of oversight and regulation. I did it from 1998 to the year 2000 before non-emergency transportation was in place. I got my van, I got the lease, and then non-emergency transportation came in. And I said, thank you very much. That would have been nice to know before the lease, that now I cannot be used. But I had to put the nickel in the tire tread to see was the tread low and all that oversight of that van. I don't want to change the oil and the tires and all that. I want to provide adult daycare. And if we have to go into the community, we're going to have that transportation. I took 11 people to the fair one time years ago. Fall is my favorite time of year. I have never in my life counted to 11 as many times in one day as I did on that day because I was head counting all day. Do I have them? 1, 2, 3, 4, 5, 6, 7. Oh, Lord. You go to the fair, you don't think anything about stepping over those big black cables that are providing power to the Ferris wheel. You take 11 people with disabilities, you're going to be thinking, oh, dear Lord, watch the walker, bump, bump, everything. There are things that we want to do, and it is great concept, but we're struggling to stay up under our own sticks and bricks to provide the services that we provide right now. So we've beat it to death that we have not had a rate increase in adult daycare since 1998. We've seen 3 minimum wage increases. Has your insurance gone up since 1998? Of course it has. Has your food cost gone up since 1998? Of course it has. Every living expense that you have, think about how much it has increased since 1998. We see it. So we understand budgeting. We understand flat budget. I just got a little bit of a rate increase under the DBHDD service that I provide, and I said, what am I going to be getting? And it went directly to my staff. There's not a profit dime in there. It is what can I do to continue to acknowledge and appreciate the staff that does a wonderful job every day. I've got to be able to turn it right back and put it into the people that provide the care. Transportation issue, Ned spoke, and his experience with that is far different than mine. Augusta, I've not had quite the trauma with that as the Atlanta area has. So I've been blessed in that area. But there are day programs that really experience transportation issues. Not only about the center to center, but transportation, the way it's provided now, it is a conduit for solicitation. You have a driver that's taking one person from this center to this center, and one center might say, hey, who are you taking over there? If you get me that person, I'll blow you a kiss. I don't know what the offers are, but they're there. It's a conduit for solicitation. So that's an issue with transportation. Rural, I can speak to that. In 2008, I opened up a rural center. A year later, another center opened up in that area. So when you speak to certificate of need, that might be something to think about because that rural community desperately needed an adult day center. I was there. It did not need 2. Now, That's all I'm going to say about that. In 2014, I closed my doors. I might be one of those 12 because I had to close. There was no room in 2, and I need to be an ethical provider, and I need to stay the course. My center in Augusta does well. I serve about 50 people a day. I am very diverse. I will speak to that in just a moment. So I needed to go ahead and focus on the layers of regulation that I have because I only did CCSP and SOURCE and a grant that I have. That's all I did in the rural community. I did not go into DBHDD or anything else. So it did not thrive. So I left. Goodbye. So that might speak to some of the needs for what the struggles in rural are. I can't speak to every area. I would be gun shy to say, hey, I'd love to be that center. I'd love to be in the area. Kind of on a small scale, in what we've done as study for a daycare, I really believe 10 people attending per day is kind of a break-even point in a small center. Would you kind of say something like that? I mean, it depends on your expenses, of course, but you can't get out there and get one referral, trickle, 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 trickle. You need to be able to hit that mark to be able to, because we have staff to client ratio. You have the sticks and bricks. You have to have the people. You have to have the nurse there. If you have one person, you have to have the RN there. Or you have to have at least an LPN and maybe a subcontracted RN that can come in and do some oversight. So you have your expenses where you have the individuals or not. So let's see, when I first started adult daycare, I opened up the door thinking CCSP was going to be one of my sources, and the VA. Those are the things that I had heard fund adult daycare. So CCSP was under an immediate freeze when I opened my doors, and because my doors in the facility that I rented I did not have 2 exits that went out, I was not qualified to get the VA contract. So CCSP and private pay were my starting point. That was 96, 97, a wonderful woman that was an advocate for her sister who had cerebral palsy. She came to me and said, I have approval to get services for my sister that are outside the scope of state-provided services. Will you see my sister? That introduced me to the world of what is now, it was MRWP, and now it's DBHDD, Department of Behavioral Health and Developmental Disabilities. That was my introduction to there. So I served that lady, and 4 of her friends. And then SOURCE came about, and I thought, wow, what a wonderful thing is. SOURCE was a pilot program, and it seemed to have the concept of what adult daycare is and should be, a hub of other services. You can have the person there getting medical oversight, the nutrition, the socialization, they're still getting other services. They can still get the care aide coming in 2 days a week to help clean. They're still going to get the I've fallen and I can't get up button. They're still going to get home delivered meals to fill in the gaps. It's not a either or when you use adult daycare. You can use us, the variance of need. It may be 3 days. It may be 5 days a week. So then, but SOURCE seemed to have it at that time. One thing that we're all seeing as these programs go on, SOURCE and CCSP, they're not now starting to, nursing home eligible has always been a statement that's been out there. And the picture of that has changed dramatically since 1996. I have had ambulatory clients that needed oversight for safety and for medication monitoring. I've had clients initially with SOURCE that had a mental health diagnosis that or a mild MR that were able to be with us safe and secure through the day, and they've now been discharged, because the criteria of what a person's eligibility is has changed, and that is unfair. I have one particular incident, a young man, he was mild MR. Our programs are not fluid one to the other. He realistically would be more aligned with DBHDD and a work-related thing. We ought to have case managers that say, okay, I got you in on SOURCE, but really your need is DBHDD. And as a case manager, that's the best thing to do for you. And so while you're getting them in that program, you serve them. But no, it comes in because he had no physical disabilities. He was eliminated from level of care, no longer got the services. Within 6 months, he called our center every day because he missed us. Within 6 months, the community that he lived in had targeted him. He was an awesome Here, buddy, carry this over there. The police ran him down for what he was carrying, and he sustained 2 broken arms. Now, if he had been with us every day, that wouldn't have happened to him. If he would have been in a work-related program, that wouldn't have happened to him. But when he was discontinued from Source, he's at the bottom of the long, long list for DBHDD. So he needs to be in a program that feeds him and doesn't put him out on the street. We're seeing that all over the place with mental health. There are people that are going through the justice system because they are not getting the oversight and the need that they could get. If they were in a day program during the day and they were getting their medications and they were regulated and sustained, and then their families could care for them in the afternoons, but we can't take care of them because they don't have a physical disability. Those things are happening in the adult day setting. Those things are happening to CCSP and Source. So you have the freezes, you have the diminished referrals, you have the people not meeting the level of care, and we've always been the least utilized service. It feels like it's been 3% since I've been a provider. When I first started serving adults in adult day setting, CCSP, their report would say, we allowed people to stay in the community for an average of 24 extra months. That's awesome. Well, then it's escalated. It's like 4 years. Is it still? Almost 5. Yeah, almost 5 years. I've seen it go 48 months, and now it's almost 5 years. And guess what's happened in that time? I was able to serve a high-functioning ambulatory person and keep them in the community for 2 years. And now I am serving an extreme, frail, desperately needing medical oversight, and we're still keeping them in there for 5 years at the same rate. Let's go back to that one just a minute. The same rate we've been receiving since 1998. Can I get an amen? So anyway, so let's see, what else have I missed? This is my first year. I'm one of the chosen 65. I have my license. I'm an adult day health provider. So I have my licensure, but just because this is the first year I get my license through HFR does not mean that I have not been regulated. I did an in-service one day because, I like to tell my clients that are attending who all these people are that are coming through the building. So I did a flip chart one day, and I said, at any given time, any one of these 13 people at a level of oversight can come visit us. And we're going to say, I had an experience, the certification team for DBHDD, they bring 5 people, they come in for a week, they were there at the end of March. Same week, door opens, there stands 4 people for the VA team. And I'm like, did I not put you on the calendar, or are you giving me a surprise? She said, neither one. I said, do you know we have another team here? She said, yes, I do. And I said, do you still want to stay? She said, yes, we do. I said, hang on just a minute. Let me figure out where we're going to put you. You go to the activity room. You guys go to the conference room, and we'll get the job done. So, I have, through CCSP, there's regulation. Through Source, there's regulation. Through DBHDD, I don't even know if you can call it regulation. There are so many T's to cross and I's to dot there. There's a tremendous amount of regulation through that program. I'm a VA provider. We receive clients through Alzheimer's vouchers, and I've written a grant in 1998 that people are not eligible for Medicaid, but they're not independently wealthy. And so this grant bridges the gap so that the grant will pay for X amount of the day, and they may have a little cost share. And they do have a cost share. So, and because I'm right on one side of the river where we live, I serve South Carolina Medicaid. And so if I'm within a certain amount of distance, the South Carolina Medicaid can use me as a center. So I just want to say that we are, it is in those levels of regulation, I will also say this, there are some that come in and say, we want you to be the best center that you can be. Let's do this. Let's make these changes. This grow. And then now there's just the undertone that we hear that, there's a level of recoupment. Now, I understand. If I've billed for a day that you weren't there, you need that money back. And I'm unethical if I did it intently. I understand giving those back. But when you're out there providing services and you've met the cost, you've met the needs, you've met the expenses, it's very hard to give money back if it was I don't know. Those, I understand. If it's wrong, if you didn't provide the service, if you lied, if there was intent, well, if you did that, there's probably going to be some legal consequences, not just recovery. But, those type things I understand. But we're still providing the services, and we're doing the best that we can. And I am concerned about going out in the community. I don't have a van. I'm going to have an expense to that to get the individuals out into the community. My day at the fair cost me at least $200 for 11 people, and that was back in the day. So, it's just expensive. That's another layer of expense that we're going to have. So, I appreciate this committee. I want to be here every time. I want to be available for questions. I'll serve in any capacity. Augusta's just right down the road. So I don't know if I mentioned in the beginning, I am an adult daycare provider, but I'm the adult daycare representative for the Georgia Association of Community Care Providers, going by the acronym GOSSIP. But we're available. Steve works with us and has relationship with several of you. So we're here. We want to answer questions. We want to be part of the solution. And we want, one thing I used to could do is I could get in the community and I could educate about adult daycare. I could market adult daycare. I'm hard pressed to get into the community now because I'm trying to make sure every layer of regulation is met. And I own the business. I employed a director in 2000. It's not that I don't have the staff to do, it's just taken all of us to do what we need to do to meet all the layers through the programs and whatnot. So I appreciate your time, and thank you.
Thank you, Ms. Madre. I really appreciate your presentation. Again, it was so helpful. I'm wondering if someone could review for us how you get referrals. Who does referring to you?
Well, a lot of times, we do need the opportunity to educate within the community. And then if that is the case, we can say, somebody might say, I need services. And then we can send those to Source or whatever program we feel that they're appropriate for. We can send a referral over so that they are brokered into services that they're appropriate for. And so private pay, they obviously can walk in the door, and then we go through the check marks of making sure they have the clear TB skin test and the history and physical and the things that we need. But if they are coming through a program, oftentimes it is in the hands of case management. And then there might be a limitation as to how many they can bring in, and there might be a limitation of the rotation system. And so, and I'll be honest, Tom Underwood he's an advocate for adult daycare, and he will say often when you see him at meetings, I don't understand why it's such an underutilized service, and I don't understand why it is not prompted and promoted within case management more, because we are so comprehensive. And I know they have to see the individuals in their home, but at the same time, there's the opportunity to come to a day program and check in with 4 or 5 people at one time, and we can give them the opportunity to do that. We are very interactive with caregivers. Everything from a head-to-toe supervisory visit once a month that says, hello, you might want to take mama to get her toenails trimmed. Those things we are doing. We're doing the head-to-toe care for these individuals, but that waffles off of referral. But the case managers do refer to us, but I don't think they value us. I don't think they understand how awesome we are. And so I think they broker services, but it's like Ned said, you may be getting a personal support aid, a button, and a home delivered meal. Why not 2 days of adult daycare also? Why? Is it the care plan limitation of finances? Is that what it is? I'm looking. There again, is that another layer of funding? Are we being underutilized? Can we take a few days of something out and use us instead? If we're $36 for 2 hours, give us a day of adult daycare, and you're not going to have a home delivered meal that day. You're not going to have the care aid. So use us instead, in addition to, not instead of.
Representative Fry.
I've got a couple questions. Can you clarify the freeze that y'all were talking about, one person per each region being allowed into the program. What is that? Where does that come from?
So we were fortunate enough the last couple of years to enroll more individuals than our budget would allow because of some enhanced federal funding. What that means is we were able to serve more people than we would normally be able to. The funds are no longer available, so we have to trip back down to a budget that's sustainable.
That's absolutely
we're
budgetary.
at that point now where we were able to serve more individuals than our budget would normally allow because of the increased FMAP enhancement. Now we got to get back down to what the budget would normally support.
Okay.
So we're monitoring that pretty closely and hoping soon to be able to get to that level again.
So basically,
there's budget to sustain who we serve, and there's budget to serve more.
Yes.
Is what our need is.
Right,
We
okay.
need
I
not
see.
only we need to serve more, and the thing is, if you give us a rate increase, tell me if I'm wrong, guys. If you give us a rate increase, but they still don't, if you give CCSP a rate increase, or if you give us a rate increase, and they're still not using us, there's still a problem. I mean, we need the opportunity to educate and this service to be promoted from within as a valid, valued program. It's got to come down. The case management needs to hear this word. Use them. They're there.
I'm sure I have a follow-up.
Okay. I'm sorry.
So, and let me clarify. So you're a private business, right?
Yes.
Okay. Are there opportunities? Are you leaving people on the table that might be eligible for the reimbursements in your community that you're not specifically reaching through your own outreach services? Like we talk about referrals as a
Right.
way to get business, but are there other ways to get more business through your own organization that we're not looking at? In other words, are you saturating the market with information about the services?
I have capacity to serve more. I'm as diverse. If there is a bucket of money out there that I can serve someone through, I have tried to be it and tap into it to the point where I have so much regulation that, it's a challenge. I mean, are there people that I could serve? Yes. And is there availability to get them on the program at this time? Maybe not.
Well, because of the cap, right?
Right.
Okay, so if the cap wasn't there, how many more would you be able to put in your program? What's the need that we're looking at? Because you're stuck to one per region per month or whatever the number was. Is it?
To clarify whether it's a Medicaid dollar or a private pay dollar as well. Were you talking, and I'm not trying to interrupt.
Yeah, no, a little bit of
Private
both,
pay
really.
dollar,
Like,
sure that there's advertising that can be done to try to serve private pay clients, but there are less and less of those people that can afford that service
Sure.
in a private pay fashion.
And I don't know, private pay does not seem to be, I'm interested that Ned said there is one center that is completely private pay, and I'm sure that depends on the community that you're in. And I'm just going to be real honest. There is a socioeconomic factor in when you serve predominantly Medicaid and whatnot, that private pay sector and that, they don't always marry up.
sure.
And so, but I have capacity to serve more.
Okay, like what I'm getting at is how many are you turning away?
Well, it's not that I'm necessarily turning them away, because if they're coming, I'm trying to serve them, but the referrals are just not coming. Am I missing it? I'm sorry.
I think like there are opportunities and some centers in specific areas where you have a potential for more of a potential for private pay, are doing a lot of work on driving the private pay clientele to the centers, and then different payment sources have different levels of need. If you were, it's hard to say what the maximum number of clients, what that maximum number would look like. I don't know that anybody is necessarily turning people away because they have because of a waiting list. I know that in other states they definitely do have waiting lists, whether they're primarily Medicaid or the service itself is more broadly available. And so in other states, there's just a lot lot more adult day centers that are there, so that you create more of a, you're able to create more of a market than the smaller community that's there. But in certain areas, there's certainly a private pay clientele that's available. It's difficult marrying, kind of pulling together, kind of mixing private pay, Medicaid, especially if you start working with the DVDHD population. Pulling all that stuff together, make it all work, is very difficult. To some extent, it's a marketing challenge. To some extent, it's a matter of putting together combining all those different services to be able to make it a strong overall service for the community.
Thank y'all.
Thank you.
Thank you, Representative. Ms. Boos? One
I'm
more
sorry.
question.
No, thank you. Anything.
That's why I was asking when I asked Ms. Ned about the referrals, because I've only worked with CCSP, and when I asked, can you send me, people that are servicing, I get a list.
Right.
And I don't know I don't know how it works with that program, if I could get information about the places instead of just a list with phone numbers, because now I begin to be the person that has to,
You have to do the
research
legwork.
and I, so I'm just calling a person, I'm here and that's spiff, but I really don't know. So now I got to come out to every center to see if that's a fit. And not only that, once I go out to see if it's a fit, then I still got to go through the paperwork to see if he qualifies for that location.
Right.
So I don't know how we could fix that to be not just be a marketing place, because I know there are case managers, but maybe a different department that does that or something, because you're not getting the people, because it all depends on who's on that other end, if they want to, take the time to call everybody, or they
Right.
just calling the first one and just sticking with that because they don't have the time. And I'm not, one person or the other, but I feel like it's several different reasons, but I don't know what the fix is, because I think you could get more people, but more people don't know about this, because we had no idea until we had to actually do it.
Right.
So I think it's just being knowledgeable that you guys exist.
And that is exactly right.
Yeah.
There's two ways to look at that scenario. One, when I have the opportunity to be in the community and educate, one of the things I tell people all the time, know about the services in your area before you need them. Predict what is coming in your future, because majority of the time people seek services really almost at a level of crisis. Oh dear me, this happened to my loved one and I need help because I still need to work every day. So then you're looking at it going, I don't have time to go to 10 centers and see whatever. And you're right, you may get. Now from the provider perspective, we don't want a care manager that is promoting and pushing one primary a center that is their friend or their whatever. We want an unbiased referral. At the same time, if we meet somebody in the community and they say, we really like your services, and we refer them and we've established that relationship with them, we want them. We've established that relationship. Now, if they don't say, I'm at Autumn Care, I'm impressed with their center, I've been there, then guess what? They may get thrown out there in the rotation. So there's barriers in that process as well. And yes, we want to be able to educate. And I'll say, you want me to come to your church? Want me to come to your Lions Club? Want me to come? I'll do it. I have been there anywhere you want me to be to educate. But at this point in time, we're trying to hold it all together under our roof. That is one of our real issues. It'd be nice to, be able to have someone marketing or whatnot. We want to meet you where you are and educate you and let you know that we're there. But we certainly want the case managers to do an awesome job of educating the people about the resources in the community in an unbiased way.
Thank you so much, Ms. Madre, and also Ms. Boos, thank you for your question.
Thank you.
Thank you very much. And we have thank you.
You're so welcome.
We have one person who has signed up to speak, and that's Mr. Tom Bauer.
was just going to clarify the rotation piece because it does work that way. Within CCSP, if a consumer knows about a provider that they want to utilize, and that's the provider the case managers will refer them to. Oftentimes, they don't know who the providers are, so we give a list of these are all the providers who are licensed. And if the person still doesn't have a choice or makes a choice, then we do what's called a rotation log. So if provider A got the referral this time, it'll be provider B next time until we get all the way through, and then we'll rotate it through again. But there is a nuance in that, I think, and I've talked to several providers who've encountered this, where they will identify a consumer, they'll be eligible for the service, they'll request the service, but emergency transportation or non-emergency transportation won't bring them there because there's another provider closer. And so the distance is an issue, a barrier for individuals to have really that choice that they would like to have. But that's just some little nuances there that are important, I think, for consumers to understand as they try to navigate what is a fairly complicated system.
And that was important information. Thank you.
And I'm sorry, just to tag in on the choice, when he uses the word choice, these individuals, on one hand, there's a press for person-centered, care and getting them their choice and whatnot, but then on the opposite end of that, there's here's you've made this choice, but you're getting this one. Those things, those two things aren't coming together. So we need to respect their choice in centers and providers as those come up.
Thank you. Mr. Bauer?
Thank you. I'm Tom Bauer with Leading Age Georgia, and I'm going to be very brief because you guys have heard a lot of information from far more knowledgeable people than I, and there were two particularly tough acts to follow. So I was just going to kind of maybe sum up a couple of things and then just add on to one of the concepts just to hopefully lay it out there for future meetings. You've heard a lot of references to case management, to SOURCE, to CCSP, and whether it's a freeze, the referrals. I hope you will pursue that further. Reimbursement as well. The thing I did want to talk about just for a minute, and there's sort of a catch-22, and you've heard it, and it really deals with both the HCBS and the non-emergency transportation. Pat was just talking about choice, and Ms. Booz was talking about the right fit, and that's one of the problems. And you were talking about person-centered planning, and that's called for in the HCBS rules. I think you need to look some more at HCBS. I think it's a work in progress, as Ned said. The department here has not gotten the clearest guidance yet, and but there's really a catch-22. And as Ned said, yeah, it sounds good to be integrated, but sure.
May I just clarify again that HCBS
Home
is
and community-based services. That is the federal rule that is saying really both, and we didn't really mention it, but nursing homes and personal care homes, all of them that are alleging to provide or advertising to provide home and community-based services must meet these new rules. It's not just adult day. But it makes more sense when you're talking about a group home for somebody who's got a developmental disability or a nursing home when you're talking about, integrating as much as possible and providing job opportunities, but clearly somebody who has a parent with dementia is segregating their parent to some extent because they need that service at adult day, and so there's sort of that catch-22 and with the person-centered planning. So I think you need to hear more about it, but I don't think it's going to get solved yet. And you probably could spend 22 more meetings on it, and that probably wouldn't be worthwhile. The other thing I did want to mention, though, is the non-emergency transportation, and I hope you will look further at that, because there's a catch-22 there, because Pat's talking about client choice, and if I'm not wrong, Dr. Beulah, that's part of CCSP, is it not? Yeah. Client choice, and yet you have, for instance, in the non-emergency transportation, which might drive where you're going to adult day, these geographic parameters, the mileage limits that Mr. Morgans was meeting. And so you might have parents who need to be at one place because of dementia, even though it's not the closest place. And so we're dealing with sort of a catch-22 there, because the transportation system is a managed care in the sense that you have these brokers who are paid a capitated rate. And so they're obviously, as a provider, trying to make money as well. And so what we really need, I would hope you will look at that and look for some more flexibility in that program. And I don't want to sound too negative about DCH, because we've had some really good dialogues, and I want to throw some kudos out to James Peoples, who has worked with us. But I think you do need to look at it, and there are certain components, because I know Pat was talking about she doesn't want to provide transportation, but I've heard Ned say, you know, I could provide transportation less than what the brokers are doing, but we can't do it within the purview of that program. We need some flexibility with those geographic limits, because people are comfortable at a certain program that are already being served. And so that fit that Ms. Booz was talking about is very important. So I hope you'll take a look at that, particularly also on the non-emergency transportation. And that's really all I had to add.
Does the committee have any questions? Mr. Bauer, thank you. Well, this committee has been so fortunate today. We have heard from Dr. James Bulott, Ms. Wright, and they were also accompanied by Ms. Ashley Fielding and Ms. Lisa Marie Shekel. And we've heard from Mr. Morgans, Mr. Ned Morgans, President of Georgia Adult Day Services, and Ms. Madre. Thank you very much for your learned presentation to us. And we have just learned so much today. Thank you for what you have given us. It's been our joy. And again, Chairman Benton, thank you. Representative Fry, Miss Yvonne Boos, and Director Jackie Emmel, thank you very much for serving on this committee. And Mr. Wasatomsky, couldn't have done it without you. And Mr. Tolbert, Julius Tolbert, thank you for your legislative expertise today. Thank goodness we didn't need you. But we thank you for being here, because we certainly could have. And you have helped us fill our goals. And our goals of the study committee are to look at the role of the importance of adult day services, to learn how adult day services fit into the philosophy of home and community-based services, just what Mr. Bauer was saying, to look at problems and formulate recommendations, and to research the value of expanding these programs for our senior citizens and for those who need care and support. So thank you so much. You've done a great job today of doing that for us, to help us learn more about this and to work very hard on this committee to come to some solutions and recommendations. Truly, we appreciate you, and committee, you are appreciated too. This meeting is adjourned. Thank you.
Thank you, Madam Chair.